Our next speaker is Dr. Nidal Moukaddam. She's an associate professor at Baylor College of Medicine and the director of Taub Hospital Psychiatry Outpatient Clinics. Today, Nidal will talk about her latest research. The title of her talk is Help Me Feel Better, Leveraging Technology for Better Mental Health. Nidal, thank you for being here.
Thank you so much for having me. I am delighted to be here. And today I am going to tell you a story. The story here is about data science and mental health and what my team and I actually think that is a marriage made in heaven. I'm a psychiatrist by training, and what we do is a lot of nuances, a lot of gray, and it's very subjective to a large extent, and it's very dynamic. It changes with the life changes that people have. Now, data science is precise, objective, and fully neutral. So it would seem on the surface that these two fields are just made to be together. And if they are together properly, what we would have is effective achievement of mental wellness. Now, that being said, this is related mostly to how we view mental illness and wellness. And so I'm going to start with the psychiatry end and loop you back to the science end, and then kind of tell you what we've been doing over the past few years. Unfortunately, for mental illness and wellness, we're bound by words, we're bound by descriptions. We describe people hyperactive, charming, annoying, depressed. And these descriptions and these words lack an objective international way to diagnose and to assess. So the way I am and the way I could be described is determined by my personality. It is very determined by my gender. It's determined by how I grew up socioculturally. And very importantly, whatever I go through in life will activate whatever genes I have. And so I may or may not end up with a mental illness depending on what happens to me. Case in point, if you have a perfectly uneventful life, you might be okay and not activate a depression gene. But let's say you live in Houston and your house flooded during Harvey, or you live in an area that was hit by a tornado, you might have depression because of that. So as we want to introduce data science into this, we are very limited by our words. Where do the words come from? The words come from what we call categorical diagnosis in psychiatry. And categorical diagnosis, simply put, is you go to the doctor and either you have a diagnosis or you do not. So basically what we're relying on is symptom cluster recognition. For example, to diagnose depression, and I use depression because it is the most common mental disorder out there, you would have to have changes in your mood, in your ability to enjoy things, in appetite, energy. Sometimes people think about death and get suicidal. So if you have a certain number of criteria for a certain duration of time, meeting a certain level of severity, you have a diagnosis. Now, what happens when you don't have the diagnosis anymore? As a psychiatrist, I would say, oh, you're in remission. But does that mean you're 100% back? Maybe, maybe not. So, of course, you can see how that could be a challenge for the data scientist. Categorical diagnosis is very helpful for clinical practice to be standardized. It's very helpful for insurance companies, for financial perspective. It's very helpful for treatment planning. But it's so dynamic that it carries a big burden when we try to measure it. In the United States, we use the DSM-5 to diagnose, and so the DSM-5 is the Diagnostic and Statistical Manual of Mental Disorders. We only started having DSMs since 1952, and the first one had 106 disorders listed, whereas the 5 we use now, which was published in 2013, has 265 mental disorders. Now, the evolution of the DSM really reflects how psychiatry and how we view mental illness has evolved as well. And so the DSM-2, which was published 7 times and had 7 editions, dropped homosexuality as a disorder. It basically reflected how people stopped viewing homosexuality as an illness and started saying, no, this is the way it is. It's just life. DSM-3, published in 1980, saw the creation of post-traumatic stress disorder, PTSD, whereas World War I and World War II soldiers who had these symptoms were called something else. And so every DSM brings about a change in philosophy. And right now, our DSM 5 has the 265 disorder list that if you go to a psychiatrist or even to your regular internist, you can get one of these diagnoses. The rest of the world, the non United States, uses the ICD, the International Classification of Disease. They are now at ICD 11. And the ICD offers 55,000 codes, 55,000, you heard me right, that can be used to classify diseases, disorders, injuries, and causes of death. And what they're trying to do here is identifying health trends and statistics globally and set an international standard for reporting diseases and health conditions. And so this is a classification that would be standard for clinical and research purposes. And it does follow the categorical diagnostic formulation I told you about. So either you have a disease or you do not. And the DSM-5 and the ICD match pretty well. So the DSM-5 has been changed to match the ICD. Now, this is not enough because, like I said, you could have a symptom, it could go away. You could have a symptom, but you're perfectly okay. You could have a problem, but you don't think it's a problem. So where does that leave you? Do you have a diagnosis or not? And so the National Institute of Health has looked at this and has acknowledged that there is a problem with this categorical approach to psychiatry, not the least of which is that we're labeling people. And so they came up with what we call the RDoC, the Research Domain Criteria. And the RDoC is a framework that integrates basic behavioral and neuroscience research and adapts it to clinical practice. And it takes the thinking from a yay or nay, do I have a diagnosis, do I not have a diagnosis, to etiology. Where does this come from? Is this genetic loading? Is this because you've been exposed to trauma? Threshold. Threshold is very important. So I might be a little bit obsessive, but my obsessiveness makes me a good researcher. One day, COVID starts, the pandemic starts, and then I can't stop washing my hands and my hands are red and chapped. That's the threshold I've crossed where my obsessiveness is now a problem. So according to the NIH RDoC, my obsessiveness is now something I could take care of, but before it was fine. And then comorbidity. Comorbidity is so important because it means that things happen together, disorders happen together. So a lot of people who go to this to their doctor or to the psychiatrist to be diagnosed, so their regular internist or the psychiatrist, will sometimes end up with two labels, not one, and sometimes more than two. And that's very confusing to people, and it's also a little disheartening. And so with the RDoC, what we have is this top-down framework that says etiology, threshold, and comorbidity, and that guides our research. What this is introducing is the dimensional approach of psychiatry. And the dimensional approach of psychiatry and mental health is very intuitive, but also very difficult. And this is why we need data science. It says basically that a symptom is on a spectrum. Past a certain threshold, your symptom may be problematic, or maybe not problematic, but at least it causes some impairment. And so instead of giving you a label of depression, I would say, well, you might be more depressed now because you're socially isolated and your depression has crossed a certain threshold. Your anxiety, it's always been great because you have been on the lookout, very alert, but now it's causing palpitations and some panic attacks. There's a problem. And so other things we could think of as being as a dimensional approach would be autistic symptoms, insomnia and difficulty sleeping, psychosis. And what I mean by psychosis is that little bit of paranoia where people might have a little bit of mistrust, which can still be okay with functioning. But when you start thinking that somebody is after you specifically and you cross into a delusional realm, then you might need more treatment. Personality measures can also be on a spectrum. So how obsessive am I? Am I thrill-seeking? Do I like novelty? Do I like to experiment? And lastly, substance use. Substance use is also on a spectrum. And what I mean by that is that I could have a drink, I could have a glass of wine with dinner and it's not causing me problems. But if I end up having 5 glasses of wine and then I get intoxicated and I cause a scene at the dinner I'm at, then my substance use has crossed a certain threshold. And if it's happening often enough, my family might say, you are drinking a little much. Maybe we can reconsider. So a dimensional approach is hopefully what mental health will be adopting, and it is increasingly adopting. And we really need data science because when we ask people how they feel, that is a self-report, and self-report is not always the most accurate. We need data science to bridge those self report measures. We need data science to quantify feelings. So if I say I'm feeling kind of down today, but you look at me and you say, oh, you look anxious actually, you look tense, you're sweating, which one is right? Am I anxious or am I depressed? So my data measurement here might actually quantify the feeling and put me on the right dimension. Data science is also super important to overcome what we call recall bias. When I'm sad, I focus on sad memories. When I'm happy, I might gloss over those sad memories. And so it is super important for data science to bring some objectivity into recall. And lastly, mental health, for any of you who've experienced a mental health crisis or know somebody who's experienced a mental health crisis, third party observation is so important. A third party might say, you look tense, you haven't slept well, you haven't, I don't know, you haven't taken care of yourself. And you say, no, I'm fine. And that gap is the gap that objective measurements can help us bridge. So we really, really, really need data science. And so um, along with Dr. Sabarwal Ashu, who is probably the most intelligent person I've ever met, we have been working for a few years. We have a fairly large team, and our first attempt was to quantify depression and anxiety because they're the most common feelings that people complain about. And we tried to design an app which has successfully been tested, piloted, and we even won an award for that. But we wanted a simple wish list. We called it Solved, and we wanted an app that anonymizes user identity, that was easy to deploy for clinicians, that was very flexible to use for the participant who would download that app on their smartphone, and that was light on battery and data. Now, ask me why an app? Because most of us have our smartphone with us at all times. So the idea of using a wearable is lovely. And I'm sure most people in this audience have used a wearable at some point, like Fitbit or your Apple Watch. But your phone is probably there even more than your wearable. You might wear that thing for a while, but then get bored with it. Your phone, you're not going to leave ever. And so our phones are very tremendous tools for us. So we set up the Solved Healthsense App platform. It was very important to discuss it with clinicians and see what the doctors wanted, because what you want as a user and what you want as a doctor are completely different. We had to design a very easy user interface, set up cloud storage, code it, and then release it. And the green box right here, the self-input, is actually the only thing we asked participants. So when you ask people things, that's called EMA, Ecological Momentary Assessment. And we asked people simple things. How do you feel? What's your mood like? What's your anxiety like? And that was combined with what the sensors told us. The sensors were going in the background. So we measured steps, acceleration, GPS, call, SMS, screen status, and ambient light. And all of this, of course, was done with patient permission. We then transferred it to the cloud. And then we matched that with that yellow square you see here, where we did those measurements in the clinic. And these measurements were basically the doctor saying, how depressed do you look? So you have what the patient is saying, you have what the doctor is saying. And this was again simple on the surface, but it had not been done, and B, it was very complex to establish. And we found a 70% correlation when people were very depressed. But when people were not very depressed, the correlation varied because the individual thinking they're down did not necessarily match with the outside observer, the doctor in this case, thinking they were down. But what we realized is that data science is so powerful and can give us a wonderful example of how people function. So this is a sample daily activity that we gather without user input. This is what my phone can tell me, not the user. This person here has woken up, and you can see as they've woken up, they have used their phone more. That's the bottom bar, that's pink. You can also see that the phone usage can be used as a proxy for sleep in this case. You can see ambient light, that's the light yellow bar. And so this person has been out in the morning. You can see accelerometry, that's the green bar, and the number of steps. So that gives me an excellent idea of what this person has been up to. And the cool thing about this is I can then track what's happening with their mood and their depression and their anxiety, because all of these measures will change and will give me a very specific digital signature once I have tracked this person. So typically, the app will need about 10 days to 2 weeks to learn an individual's patterns. Once we learn the patterns, we end up with an individualized baseline. And that baseline will vary when the person is happy, sad, depressed, etc. Now, the other thing that we established as a really good proxy for depression is the location. So individuals who were depressed or who were reporting being depressed, they really didn't move as much. So using heat map visualization, they had less motion in their regular life, and that may have reflected less socialization. So this is fairly concerning. And lastly, one other thing that the app can give us that is very helpful is that you can have a graphical representation of the individual's social network. An individual's social network is, of course, not just who they talk to, but also who they email and who they contact electronically. In this case, this is a social network established from call log and SMS, so not online. And what you see, this person contacts these individuals, but you see the first two right here, they've called the first person 32 times and the second 29 times in a week. And that means these people are close. So if I put that together with clinical data, and I know that this person just had a breakup, and that breakup means that these 32 calls are gone, then I can see how this person could get worse. Now, put that with a different kind of clinical context. Let's assume that person had been drinking or using drugs, and those 32 calls were made to their drug dealer. Then I would be very happy to see those 32 calls gone. So you see here that this image, this graphical representation is very helpful, but is also potentially very invasive. So with the COVID pandemic, what we have transitioned to do, this is our latest project and it hasn't been published yet, so I'm just going to give you a teaser with the results, is take what we know about measuring mental states and see how COVID has affected them. And this time, the system architecture was a little bit different because we wanted even more anonymity than with an app, because an app requires you to sign up, and so we are gathering some info there whether we like it or not. So in this case, what we used is a third-party provision called Twilio, and Twilio will send text messages. That means that you sign up with your phone number, but you do not have to put an app on your phone. So no sensor-based measurement. I'm only getting those ecological momentary assessment responses. And then I'm asking you how you feel, how things are going with the COVID pandemic, etc. And COVIDsense is an adaptive and a longitudinal study. We actually think it is the only longitudinal study for mental health that's been conducted since the pandemic started. There's a lot of studies out there that talk about cross-sectional results, i.e., how do people feel? But we have a longitudinal follow-up that says, here is how people's mental states have evolved. So the various operations here will basically be the app, covidsense.org, triaging who you are. Are you a healthcare worker? Are you a COVID patient? Are you a caretaker? And the app will then modify the questions you ask based on that. So your profile would look different than somebody else, and the questions you get asked are different based on who you are. And so those EMA responses are stored separately than the other database elements to maximize privacy. And this has worked very well for us. We have close to 1,200 participants, and we have most of our participants coming from the United States, though we have a pretty nice recruitment from other places. We interestingly found that participants reported a lot of pre-existing conditions, so mental health issues, cardiovascular issues, pulmonary issues. And when you think about that in context of the COVID pandemic, you realize that this is very serious because pre-existing conditions are probably the scariest element if you do get COVID. And so we have more women than men. Women were also better at responding to questions. Most of our patients are between 25 and 60, but we do have a pretty nice representation of the elderly population. And here's a small teaser of what we found. If you follow the red line are individuals with pre-existing conditions, whether physical or mental. And you will see that individuals with pre-existing conditions had more poor to fair mood. They're more in the bottom half of the screen. And what that tells me is that these individuals were more sensitive to life events. So the COVID pandemic has affected them more. And by dragging the mood down, this is a very significant issue because it could potentially mean that these are the people who are getting more depressed. And of course, when you get depressed, it will affect how you function and how you perform your job and how you deal with your environment and your children, etc. The next time series is also showing how mental health was affected due to news. So as many people have complained, the news have been overwhelming. And what we see here is the red line again is individuals with pre-existing conditions, and they are more affected by the news per their self-report. Now, does this translate into depression that needs treatment? Does this translate to sleep issues? Does this translate to more alcohol use? These are all very valid questions that we are exploring in Healthsense. And this would not have been possible without data science. So this is why I think data science and mental health are made perfectly for each other if we follow certain rules. And so here are the rules that our team has learned the hard way. First, user privacy is so important, and we have to do our best to protect user privacy. So for research studies, we get approvals from Baylor, Rice University, and Harris Health. All our projects are triple IRB approved. But beyond that, we also encode our data. So for Solved and Healthsense, we had used MD5 hashing. We have access control. But I think one thing that I credit the engineering team for, and I think they've been amazing at that, is that they have not done linguistic analysis. We never asked the IRB to allow us access to any recordings. So it would be easy if I recorded what you say and then picked up the negative words. But we're not doing that. We are trying to detect and predict what's happening with a person without actually invading what they're saying, what they're typing. And so that, I think, is a very important step in the success in that union of mental health and technology. Step 2, we have noticed that our data points are ridiculously mismatched. So when I look at sensor-based data points, we're talking about tens of thousands of data points per day per participant. But clinical data points are much fewer. So here you have the PHQ-9. This is the most used depression questionnaire in the world, and it only has 9 items. You can see them. I've been feeling down. I've had my appetite disrupted, my sleep. I've been hopeless. I've been thinking of death. Very, very limited data points. So step 2, and this is a lesson we've had to learn over years, clinical data points and sensor-based data points are not matched in numbers, and this is where statistical magic comes in. Step 3, carefully pick your dimensional measures. So we are very trained to think of measures that are illness associated. Are you depressed? Are you anxious? Ooh, are they going to hurt themselves? Should I call the police? Are they paranoid? But It might be more useful for us going forward as a field to pick neutral dimensional measures that have no specific disease association. For example, can you concentrate well? Are you lonely? How sociable are you? Have you been impulsive? Oh, 3 slices of pizza. I might be okay with 3 slices of pizza, somebody else might not. How much alcohol have you had? Are you smoking marijuana? And so these are things that are neutral. And they do not have specific disease correlation, but they might be better for us when we try to improve somebody's health. And then lastly, and this is my last slide, consider your audience when you are designing a data science project. Most of what we do is, of course, we want our patients to be super happy. We want them to feel better, have good sleep and energy, and be active. But the clinicians are looking for something different. So we're looking for diagnosis to be certain. We're looking for a supplementation of what a patient remembers or tells. We're looking for tracking of high risk behavior and medication adherence. And we're looking for things that are confidential and private so they can fit in your medical records. And so, with that being said, let's open the floor to questions. And I want to thank everybody I've been working with. There are many more who wouldn't fit on this slide. Thank you.
I wish we had time for more questions. I could talk to you for like half an hour. I think the one thing that kind of stood out is like, do you have an idea on whether or not people are becoming more resilient as a function of time? Are we getting used to this, or is it actually, are we deteriorating?
I think most people deteriorated within the first couple of months. And now that we realize that it's going to be with us for a while, most people are adapting. Either they have gotten help or they have realized that this is what it is, this is my new norm, and I'm going to stick with it for the next year or so.
I really want to ask you this question because I think this is really important. A lot of people I know are struggling with this pandemic. They seem down. How can I help?
So I think the first thing to do is remember that when we talk about social distancing, we want to think physical distancing, but not real social distancing. You don't want to be isolated because that is a killer. It's bad for your health. It's bad for your mental health. It's bad for your body. You want to be physically safe, but you want to create as much of a bubble as you can with some people that you are confident that will be good for you and they will not actually go around and catch the virus. And if you create a bubble, then you can maintain some social interaction, and that would be very protective. Now, if you think somebody is very ill, and I would say get care. Even your internist can do it. Your primary care physician can do it. It doesn't have to be going to the specialized psychiatrist right away. It's okay if it's somebody who's on the primary care end. And sometimes a little bit of validation, a little bit of psychotherapy is all it takes. Not everybody gets on medications.
Thank you so much for being here. I can't believe how focused you were during your talk, considering you're surrounded by the noise of a hospital.
I am so sorry about the noises.
No, but it was impressive to watch you. I would have been distracted. Thank you so much for being here. We're moving on to our next session. David Eagleman will be talking in about 10 minutes. I'd like to thank Hewlett Packard again for being our sponsor. See you guys all in a few minutes.